Few people still joining. Right, okay, so let's start. So today's session is on the respiratory system, and I hope that you've done your homework from yesterday. If you haven't, please find some time to do it before this series of lectures end. Okay, so we have a few more sessions to go, but make sure that you do what I asked you to do yesterday. That is to summarize the physical signs of the cardiovascular system. Okay. Fine. Okay. Right. So today's session is going to follow a similar structure, slightly different in the fact that I will be discussing interpretation of physical signs as we go on. So it's a slightly different structure from yesterday, but it's easier, especially with the respiratory system, to discuss some of the physical signs as we go on, discussing the basis as well. Okay. Hi. So let's start then. And as usual, you can put any questions you have on the chat. Okay. And make sure that you share it with everybody so that everybody knows what you're asking about. Okay. The classroom thing is fine. So we'll be posting the stuff on that so you can use that. People who have not joined, please join, where I think there are some more people to join there. Okay, fine. Right, so examination technique of the respiratory system. So remember, we'll be learning about technique as well as interpreting physical signs. Now, just to start off, a little word of caution about the respiratory system. It is probably, even though you don't realize it, a slightly different, difficult system to master. Now, you might think that neurology is the most difficult, but respiratory can be quite difficult because interpretation of physical signs can be slightly more challenging in the respiratory system. In neurology, it's very, very clear. It's obvious for everybody. It's just that you need to know how to interpret it. But in respiratory, the actual detection of the physical sign might be slightly difficult. Right? Then cardiology, if it's a murmur, you hear the bloody murmur. But in respiratory, it's a bit more difficult. So that's a little word of warning before we start. So it needs a lot of practice. Hurry. So like in the cardiovascular system, you start off with a general examination and then proceed to examination of the respiratory system proper. And this consists of several steps: inspection, palpation, starting with the tracheal examination. Never forget the tracheal examination, very important part of the examination. Okay. Then percussion, and finally auscultation. So the 4 steps of inspection, palpation, percussion, auscultation. Especially remember that tracheal palpation is important. Some of you forget it when you focus only on the chest and the chest wall. Okay, so this is the general structure. Now, when it comes to general examination, like in the cardiovascular system, clubbing plays an important role. And if you find clubbing in the general examination, it's a very useful finding because respiratory causes of clubbing, one could be due to a carcinoma. So bronchial carcinoma can cause clubbing. Okay, bronchial carcinoma. Especially you see this in squamous cell cancer of the lung, bronchial carcinoma. Then you also see this in pulmonary fibrosis, or you call this diffuse parenchymal lung disease or idiopathic pulmonary fibrosis, various words used. Okay, a diffuse fibrotic process. So in interstitial lung disease or IPF, also known as diffuse parenchymal lung disease, clubbing is a feature. Clubbing is also seen in respiratory disorders which are purulent or pus forming in nature. Okay, purulent, pus forming in nature. So these can be abscesses, lung abscesses, and empyema. So these are the clear-cut causes of clubbing due to respiratory problems. Bronchial carcinoma, pus forming, purulence forming infections like abscesses, and also empyema, and as well as bronchiectasis. This is also bronchiectasis, also a disease where there is recurrent infection and resolution. And then you also see clubbing in patients with diffuse parenchymal lung disease, also known as interstitial lung disease or idiopathic pulmonary fibrosis. Right. So you also see clubbing in these conditions. Right. Remember COPD, write this down. COPD does not cause clubbing. TB can rarely cause clubbing. It is not a common feature of TB. It can rarely cause clubbing. COPD never causes clubbing. Okay, so make sure that you don't make these mistakes. So important, it gives you a nice series of information if you find clubbing in the general examination. These are nicotine stains. Okay, evidence that the patient is smoking quite a lot. And also, again, I emphasize in the general examination, look out for features of malignancy. Okay, and I will explain why this is important later as well, because sometimes malignancies of the lung can be difficult to detect on examination alone, that is examination of the chest. But it is far more obvious when you look at the general examination findings. Okay, and what are these? As you know, a tumor at the apex of the lung can cause Horner's syndrome, so watch out for Horner's syndrome, okay, because it compresses the cervical plexus, the cervical chain. A tumor again in the superior mediastinum can press on the superior vena cava, causing SVC obstruction, okay, SVC obstruction. And SVC obstruction causes fixed dilated neck veins, and obviously you don't see this in our dark-skinned people. When they lift the hands, the veins become more engorged and obviously the face becomes more plethoric. Okay, but even in our people, you can see this plethora, especially in the conjunctiva. So if there's a tumor in the mediastinum pressing on the SVC, this is another key feature that you would look out for. Engorged neck veins, distended engorged neck veins, and also plethora of the face, especially exaggerated when the patient raises the arms. This physical sign you also see in patients with a large retrosternal goiter. So SVC obstruction again due to pressure effects of a malignancy. Why is this important? Again, because sometimes detecting a malignancy directly from examining the chest can be difficult. Flaps and a bounding pulse. Sometimes you feel the hands, they are warm, sweaty, and there are flaps. And I have shown you what flaps look like in the picture on your right side. This indicates carbon dioxide retention, which is a very important feature that you see in patients with COPD. Okay, carbon dioxide retention, flaps or asterisks. Ankle edema, again a good physical sign for you to look out for in the respiratory system, and that indicates right heart failure due to cor pulmonale. That is, because of lung disease, there is pulmonary hypertension, and that causes right heart failure. So this is another sign to look out for. Right. Now moving on to the respiratory system proper. So I told you there are 4 steps, just revision of this, you know this already. Inspection, palpation, percussion, and auscultation. Start your inspection from the foot end of the bed. Okay, foot end of the bed. And a key thing that you see from the foot end of the bed would be apical flattening. Okay, apical flattening. And also, by close inspection, you should be able to identify the barrel-shaped chest. So barrel-shaped chest basically is the anteroposterior diameter is as equal or greater than the transverse diameter of the chest. So you might see a barrel-shaped chest, you might see apical flattening. And this is a good example of apical flattening. And also you can see use of accessory muscles of respiration. Apical flattening basically means, if it's unilateral, it's very important because it basically means fibrosis of the lung in that area. So write that down. Apical flattening, when it's unilateral, okay, you're looking for evidence. It indicates that there is, you see there as well, you see unilateral apical flattening, and that indicates a fibrosis of the lung on that side. And it's much more clearer when you look at the foot end of the bed, from the foot end of the bed. All right, moving on to palpation. Here I have demonstrated the proper way of tracheal palpation. So I told you palpation, don't forget the trachea. Tracheal palpation is done in this sequence. Okay. And this is how the proper technique of examining the trachea. And all of you know, you keep your two fingers on either mandibulosternal joint and try to push your finger between the sternocleidomastoid heads and the trachea. If the trachea is in the midline, you should be able to move your finger in both directions in an equal manner. Okay, fine. So that is palpation. And all of you know, as I told you, I will discuss the physical sign interpretation as we move on in this discussion. And you know that, okay, tracheal deviation can be either toward the side of the lesion or away from the side of the lesion. Toward the side of the lesion would be due to collapse, fibrosis, or, for example, removal of a lung, pneumonectomy. Okay. Away from the side of the lesion would be a pneumothorax, or in some instances, a massive pleural effusion, which pushes the mediastinum to the opposite side. Okay. The trachea can be pushed due to other reasons like upper mediastinal masses, cancer in the upper lobes, okay, or enlarged lymph nodes in the upper mediastinum. So these are some of the causes of tracheal deviation, very important physical sign. So palpation starts with examination of the trachea, and the most important thing to look for is tracheal deviation, and could be away from the side of the lesion or could be pulled towards the side of the lesion. Okay. Palpation then focuses on the chest. The chest palpation consists of looking for chest movements. Remember, this is not chest expansion. Don't use the word chest expansion. Chest expansion is measured with a measuring tape and is only valuable in probably in pediatric patients, right? Where you measure the expansion in centimeters. Okay, not important in medicine. I'm not going to talk about that. What we are checking here in this technique is chest movements. And please look at these pictures where I show the proper technique of looking at the chest movements in the upper zones, middle zones, and lower zones. If you look carefully at this picture, you can see that the tips of my thumbs are pointing up and they're not in contact with the chest wall. Your thumb is in contact. It's a pulp of your thumb is in contact, but the tip of your thumb is lifted away from the chest wall. This is to make sure that your thumbs move apart with the breathing movements. So upper zone, middle zone, and lower zone. Okay. Now, what can be abnormal in the chest movements? Chest movements can be generally diminished all over the fields or bilaterally, or it could be reduced in a certain region, and we'll come to that at the end of this discussion. Okay, so make note of that. Right. Then in the palpation, so we have looked at the tracheal examination, we have done the tracheal examination, look to see if it's deviated or not. Then the next palpation thing is you do the chest movements, right? Make sure that you encircle the chest properly. It's difficult to do for people with very small hands, but you encircle the chest properly. Make sure that the tips of your thumbs are not in contact with the chest wall and restricting the movement. Okay, and don't press too tightly because that will also restrict the movement. And you can observe your thumbs moving apart like what I'm showing now. And remember, chest movements can be diminished generally or it can be diminished in a particular region only depending on the pathology. This is vocal fremitus. You keep your the hand in the way that I have described, that is the ulnar border of your hand, in between the ribs in the intercostal spaces, and ask the patient to say 99. Okay, 99 කියලා කියන්න and compare the two sides. Okay, compare the two sides. And very important, write this down again. When you check for vocal fremitus, make sure when you're going down, move more laterally. Okay, move more laterally away from the midline. That is because in this region, you have the liver. Okay, in the middle, you have the heart. So there is no point in checking for vocal fremitus in that area. So make sure that you move your hands more laterally as you go down. So please make a note of that. As you go down, move more laterally. And I have demonstrated that in these two pictures. And make sure, again, write this down, because these are the things that you might forget, and these are things that you have to now learn. The vocal parameters should be looked for in the axillae as well. So axillae, you need to check, and remember the technique is demonstrated in the two pictures on your screens. Okay, the technique of examining the axilla for the vocal parameters. So 99 and examine that. Anuname. So what does vocal parameters look at? It basically, when you say 99, there is a vibration that is generated and that is transmitted through the air passages and then through the lungs across the chest wall. Okay, across the chest wall. Okay, the vibration is generated in the larynx, and the way you say anuname, it's a relatively low pitched tone, and then it causes a vibration which is transmitted down the bronchial tree, across the chest wall, and into your hand on the skin. Okay, that is what you are doing. And basically, the vocal parameters depends on the pleural space. Okay, pleural space quite significantly. Okay, on the pleural space. Okay, and in any condition, okay, sorry, give me a second. In any condition where the pleural space is sort of, the pleura are stripped apart, okay, the pleura are stripped apart, vocal parameters is reduced. So this is, for example, if there's a pleural effusion, for example, the pleura are stripped apart and the lung now does not have any communication or contact with the chest wall. So in a pleural effusion, the vocal parameters reduces. But say the lung is fibrosed, okay, that is a more solid mass. Lung is fibrosed, but the pleura are perfect, pleura are fine. They are in nice contact to each other and with the chest wall. So now, as you know, a solid vibrates much better, and when the lung is fibrosed, the sound is transmitted much better across the chest wall, right? So take those two examples. So vocal parameters can be reduced or increased. Vocal parameters is reduced when the pleura are no longer in contact with each other and there's something within the pleural space where the pleura are stripped apart. So this is, for example, pleural effusion or pneumothorax. But when the lung is fibrosed, the pleura, there is no problem with the pleura, the lung is fibrosed, then the vibration is transmitted better. So in lung fibrosis, for example, the vocal parameters increases. Moving on. Okay. And also in a consolidation, again, when the pleura, the lung tissue is more solid in nature, the vocal parameters increases. So this is just a note for you to read. I have described this already. Okay. Fine. Percussion. So this is the guy who initially described percussion, and this was because this fellow's father was a person who made wine. So basically what they did was they filled the barrels and kept. And then percussion was used to find out how much wine was left in the barrel. Okay. And this fellow's son was the first person to apply this to medicine. Okay. So that is how percussion was used initially to find out how much wine there was in a wine barrel. Okay. Okay. And these are the zones where percussion should take place. Okay. And two key things again underlined right down. Anteriorly, the percussion, again, as I told you, should go laterally. Okay. Should go laterally as you go down. Okay. Again, because here you have the liver dullness, and 3 and 4, numbers 3 and 4 are basically over the liver. But laterally 5 and 6, and also percussion in the axilla will give you the real lung tissue percussion character. And in the back, make sure that when you go down, percuss in two places. Don't percuss over the scapula. Don't percuss over the scapula. And a slight trick to get the scapula out of the way when you're percussing is to ask the patient to keep the hands like this. That brings the scapula apart, exposing this chest wall, little bit of chest wall in the middle. But as you go down, there is no problem. You can go laterally and you percuss in two places. Okay. So these are key technical aspects that you need to follow when you're percussing. And remember, so this is the technique again. Percussing over the clavicle usually is with a single finger, and then percussion there. Okay, I have shown the proper way of percussion. Okay, so observe these pictures. It will show you how to percuss. Okay, and this is percussing in the axilla and going more laterally as you go downwards. Now, if you talk about percussion, percussion can be of 3 types. 4 types actually. 4 is starting with normal. You can have normal percussion. You can have stony dull percussion, or resonant percussion. In resonant percussion, it's like a bereyak gahanawa wage. Okay, bereyak gahanawa wage. I don't know whether Temia is around. Probably not. He's probably sleeping or playing baseball or something. But basically, it's like hitting a drum. Okay, so there is resonance. Unattawa matak kara kiyapam me api panti karana again. So basically, resonance is like you hitting a drum. Okay, it's resonance. It's very, very obvious. Nikan tattu karama hondara sadde aheno. Right? Dull and stony dull, both the sound is dampened when you percuss. Now, I'm going to teach you a very important point here. Please write it down. What is the difference between stony dull and dull? Okay, stony dull and dull. Stony dull kiyanne is the sensation you get when you sort of percuss a wall, for example. And it is the sensation you feel on your palpating finger, like you're hitting a ball. So it's not the sound. Stony dull percussion is not the sound. It is a sensation that you feel onto your palpating finger, right? And it is exactly like percussing on a stone wall or a solid wall. Dullness, nikan dullness, you don't get that feel. It's still a little bit of a springy sensation, but the sound is dampened. So this is slightly different, okay, from one another. So stony dull percussion, resonant percussion. And as you know, stony dull percussion is due to fluid in the pleural space, and that is pleural effusion. Dull percussion kiyanne something like what you get in a consolidation or a mass, for example, in the lung. Resonant percussion occurs when you have air in the pleural cavity, and that is in a pneumothorax. So, eva issarahin evat liya ganna. Hari. So, right up to there, we will just revise what we've done now. Okay. So, inspection, start inspection from the foot end of the bed. Look specifically for apical flattening. Look for features of barrel chest, for example, right? Apical flattening, use of accessory muscles of respiration. Palpate the trachea and see if it's in the midline, whether it's shifted or not. If it's shifted, then it could be towards the side of the lesion or away from the side of the lesion. Palpation, remember to do the chest movements in all 3 zones, proper technique. And vocal fremitus, remember as you go down, go laterally and examine the axillae specifically. Vocal fremitus can be increased or reduced. Vocal fremitus is increased when the lung becomes more solidified. For example, fibrosis or consolidation. Okay. And vocal fremitus is reduced when the pleurae are stripped apart and there is fluid or something inside the pleural cavity. Percussion, proper technique, the sites that you need to percuss, very important. Okay. And then go laterally as you go down, percuss the axilla, make sure that you do that. තේමිට කවුරු කියලා හොයනොයි කියලා. හරි පාරෙන්කෝ බලන්න. Right. Right. Okay. So percussion can be stony dull or resonant. Stony dull is a sensation like you percussing against a stone wall. Dullness is like when you're percussing over a mass or consolidation. The difference is it is a sensation that you feel to your percussing, palpating finger. Dullness is more springy, more spongy sensation to this finger, but it is the sound is dampened. Sound is dampened. Resonant percussion is basically like you hitting a drum. Hari, now any questions up to now, because I'm going to go to auscultation, which is a slightly different ball game. So post any questions if you have, and I will answer them. Hari. Now, when you auscultate the lungs, you're listening for breath sounds. Now, when it comes to breath sounds, you have to comment on, number one, what type of breath sounds these are. The type of breath sounds. There are two types of breath sounds: vesicular breathing breath sounds and also bronchial breath sounds. And that's one thing. So that is a character of breath sounds. Also comment on the intensity of breath sounds. Also, we are talking about added sounds, crackles, ronchi. Those are added sounds. So when you're auscultating, keep your ears open for these things: the breath sounds, the character intensity of the breath sounds, and also added sounds like crepitations or ronchi. Then ahaganna hondata. Now these are the characters of breath sounds, and I will explain this again. On the left is vesicular breath sounds. On the right is bronchial breath sounds. Okay, and you can see significant differences between the two. In vesicular breath sounds, you have inspiration and expiration. Expiration is softer and shorter. Okay, it is softer and shorter. And there is no gap between inspiration and expiration. So vesicular breath sounds are, you have an inspiratory phase, you have an expiratory phase, but there is no gap. And remember that the expiration is softer and shorter. Very, very important. If you don't know this, you can just forget passing the respiratory short case. Now, bronchial breath sounds are different. Okay, bronchial breath sounds are different, where the expiration now is louder and longer than the inspiration. And the actual character of the breath sounds also sound more harsh. Okay, like that. So more harsh sound and you can basically get a gap between these two. So in bronchial breath sounds, you have expiration louder and longer, and there is a gap between the two. Now, I'm going to give you a little bit of information about vesicular breathing. Now, remember, make a hondata haganna, otherwise you won't understand this. Now, how are breath sounds generated? How are breath sounds generated? Now, remember that when you breathe, there are sounds that occur in your bronchial tree, which I have shown on the right side. So, when you breathe, there are sounds generated within the bronchial tree. Okay? There are high-pitched sounds. Again, people who do music obviously know this. High-pitched sounds and low-pitched sounds that are generated. High-pitched sounds and low-pitched sounds that are generated. They come in. So when air passes through air passages, the vibration turbulence generates these sounds. Some sounds are high-pitched, some sounds are low-pitched. High-pitched sounds mainly come from the upper part of the airway, trachea, and the main bronchi. And you can actually listen to this. If you keep your stethoscope over the trachea, you'll hear a very harsh, high-pitched sound. So they come from the top, okay, proximal airways. The lower-pitched sounds, okay, come from these lobar and segmental bronchi and the small air passages. Lobar, segmental, smaller air passages. Then ahagan. What usually happens is, so when we keep the stethoscope there, we are listening to the sound, the breathing sounds transmitted through the alveoli into the stethoscope. Now the alveoli act as a filter. Okay, again, if you do music, you will know you can set a filter. If you are doing sound engineering, Sanjay Herath will know very well about this. So basically, when you can filter off sounds, and the alveoli act as a filter, and it filters all the high pitched sounds away. All the harsh sounds are filtered away. Okay, all the harsh sounds, high pitched sounds are filtered away by the alveoli. This is a normal vesicular breath sound. So usually vesicular breath sounds are low pitched. Low pitched. So I'll explain that again. When you're breathing, noises are generated in the respiratory system. The harsher high pitched sounds are generated sort of in the proximal airways, central airways. The low pitch sounds are mostly generated in the segmental and lobar airways. The alveoli act as a sound filter. It absorbs and filters sound. It filters out the high pitch sounds, the harsh sounds. And what you can only hear to your stethoscope is a filter game. So those are low pitched sounds and quieter sounds. So this is vesicular breathing. Okay, vesicular breathing. Fine. So in vesicular breathing, you get inspiration and then expiration. Okay. Expiration is shorter because remember it's a passive process. So the turbulence is less. Okay. So the turbulence is less. It's a passive process. So turbulence is less, hence it's shorter and softer. Now, so basically, there is a lot of noises generated in the respiratory system when you breathe. High-pitched sounds are not heard because they are filtered off. The harsh high-pitched sound that you hear over the trachea are all filtered through the alveolar mechanisms. They are filtered out. So the only thing you can hear is mostly low-pitched sounds and a bit of some of the high-pitched sounds. Okay, and basically you hear inspiration, which is the sounds coming from the lobar segmental airways, and then finally you hear expiration because of the backflow, and it is more of a passive process, so it's softer and shorter. Hari. Now what happens in bronchial breathing is this alveolar filter. So this is all the features of vesicular breathing. Soft and low pitched. Inspiratory phase is longer than the expiratory phase. Intensity, that is a volume, is actually louder in the inspiratory phase. Expiration is a passive process, so turbulence is less, softer sounds. Okay, and there is no pause. What happens in bronchial breathing is bronchial breathing occurs because this alveolar filter doesn't work. The alveolar filter doesn't work, it's broken. And a classical cause of bronchial breathing is consolidation, where the alveoli are all filled with fluid. They are all filled with fluid. Okay, alveoli filled with fluid. So the alveolar filter is broken, it's not working. So therefore now you begin to hear the higher frequency, higher pitched sounds, because the alveolar filter is not working. So anything in the alveoli, consolidation, blood or whatever, fibrosis destroying the alveoli, you're losing that alveolar filter. And now you're hearing harsher breath sounds like you would hear over the trachea. Okay? And so these are higher pitched, harsher sounds that you would hear, for example, like over the trachea, because the alveolar filter is broken. It's not working, it's not filtering off these high pitched, harsh sounds that it usually does. It's its usual function. So therefore, you would begin to hear bronchial breathing. And why is there a gap here? Because air does not enter the distal air passages. Again, because alveoli are gone, they are full of something. Air does not enter the distal air passages. So there is actually a gap between inspiration and expiration. Okay? And that's called the alveolar pause. Don't worry about that word. Right? So hollow, high-pitched sound, and you know the difference. There is a gap and the expiratory phase is longer and louder. And there's something called whispering ventriloquy that you get, okay? And that is where over area of bronchial breathing, if you ask the patient to whisper, eka, deka, tuna, hatara, you can hear that very, very clear. And that's called whispering ventriloquy. And that's a very good sign to check for if you are not sure whether this is real bronchial breathing or not, okay? So, rahasing, ekai, dekai, tunai, hatarai kiwama, you can actually hear that very clearly over an area of bronchial breathing. Okay. And you can actually hear bronchial breathing if you keep your stethoscope either here or right at the back. Okay. Right at in the interscapulator. Normal කෙනෙකු get bronchial breathing ඇහෙනවා මැද මේ හරියට. Fine. So why does bronchial breathing occur, lamai? Because of the loss of the alveolar filter mechanism. That is the reason why you hear bronchial breathing. Okay. And it usually the alveolar filter filters off all the high-pitched harsh sounds, which are now you are going to hear, and it sounds like whereas vesicular breathing is far more quiet. Bronchial breathing is very harsh and high-pitched. This is because alveoli are broken, they're dysfunctional, and there is stuff inside. And it's not filtering the high-pitched sounds. There are various types of bronchial breathing, which I don't think you need to worry about. But bronchial breathing can be heard in a consolidation, sometimes above the level of a pleural effusion, and in pulmonary fibrosis. Okay. Forget the last one for the moment. I will tell you later why that is important. You can also hear bronchial breathing over a cavity. You can hear a bronchial breathing over a cavity. And I'll come to that in a bit. Hi. Now the last thing to do is when you're examining the respiration. So clear the balance. So breath sounds, what do? You listen to the breath sounds, bronchial breathing, vesicular breathing, and then try to figure out whether it is vesicular or bronchial. And now you know the explanation of how bronchial breathing occurs, and that is due to the lack of the alveolar filter, which usually filters out the harsh, high-pitched sounds originating from the trachea and the upper, very proximal airways. And the gap is there because air no longer enters the alveolar, and there's a pause, therefore. Okay. Bronchial breathing is heard over consolidation and fibrosis, and also above the level of a pleural effusion. Bronchial breathing can also be heard over a cavity. Right, now finally, we talked about whispering ventriloquy, and you can also check for vocal resonance, which is the same as vocal frequency. Right. Now you go on to listen to adult sounds. Adult sounds, wheezes, crackles. Wheezes are also called ronchi. Crackles, you know. Plural rub. Squeaks, are interesting sounds. Stridor is not very important because it's important, but not for an exam situation. You will never get a patient with stridor for the exam. Right. Now, wheezing or ronchi can be polyphonic or monophonic. Polyphonic කියන්නේ musical piece එකක් වගේ. You get multiple notes in the sounds. Okay, polyphonic. And that is classically seen in asthma and COPD, specifically in asthma. Monophonic is just the wheezing sound. You know what a wheezing sound sounds like. It is a single note every time. And monophonic ronchi can be seen in tumors obstructing airways. So, polyphonic ronchi තමයි asthma වල ඇහෙන්නේ. Sounds very musical, various notes coming in and out. Okay. And monophonic ronchi are more single sound, and it is often due to obstruction of a bronchus. Read all this later. Stridor I'm not going to talk about. Right. Squeaks again are sounds that you hear towards end of inspiration. I won't talk about that very much. When you go to your appointment, somebody will show you how it sounds like. Crackles we are going to talk about. Crackles can be fine crackles or coarse crackles. Fine crackles or coarse crackles. Okay. Now, it is a frequent problem where we find medical students cannot differentiate fine crackles from coarse crackles. It's not only medical students, it is generalizable to the whole medical community, postgraduates included. So fine crackles, coarse crackals, obviously sound is different. Fine crackles are the sound that you get when you're sort of doing like that with your hair, okay, and you can hear a sound. That is fine crackles. Coarse crackles is like when you're crumpling a piece of paper. But there are other differences between fine crackles and coarse crackles, which you can read. Fine crackles are almost always heard in the lung bases. Okay, remember that as the most important point. This table gives you some other features which you can read as well. Okay, so crackles early in inspiration are seen in COPD patients. Okay, bronchiectasis is the classical cause of very coarse crackles, and these are heard throughout inspiration and expiration. Late inspiratory crackles or end inspiratory crackles are classically seen in, that is, crackles occurring at the end of inspiration. These are usually fine crackles. You see this in ILD and pulmonary edema. Okay. And a pleural rub is, so that's about crackles. A pleural rub occurs when there is pleural inflammation. It's a very scratchy sort of sound, a scratchy sound, which is different from the sound of a cracker. Right. So these are some of the features that you look for as added sounds. So wheezes, just to refresh your memory, revise what we've discussed. Wheezes can be polyphonic or monophonic. Polyphonic is very musical, many musical notes coming in and out. Asthma is a classical example for causes of polyphonic crackles. Wheeze. Monophonic wheeze is when you get obstruction. It is a single note that you hear, or bronchial obstruction. Crackles can be fine crackles, coarse crackles. The main difference is fine crackles are usually lung bases and it is heard exclusively in inspiration. Coarse crackles are heard both in inspiration and expiration. Okay. And there are other features in that table that I have given you. Crackles, early crackles in inspiration can be due to COPD. Coarse crackles in inspiration and expiration are seen in bronchiectasis. Okay. And finally, end inspiratory fine crackles are seen in interstitial lung disease and pulmonary edema. Squeaks are squeaking sounds, as the name implies, not very important. A pleural rub is a scratching sound that occurs when there is pleural inflammation. And look at these tables differentiating between fine crackles, coarse crackles, and also the difference between a crackle and a pleural rub. These are self-explanatory tables. Now, I saw Paisal had asked a question about when do you do the posterior examination? Yes, Paisal, posterior examination, you finish the anterior part and then go on to the posterior part, and you are supposed to do the front and then go to the back, unless you are specifically asked to do the back first. Sometimes example examine the respiratory system from the posterior aspect here. Obviously you start from the posterior, but don't forget the tracheal examination. Okay, fine. And I forgot to mention, don't forget in the general exam, lymph node examination. Achala, Krebs is similar to crackles. It's the same term, or at least used interchangeably. Sarangani, is it? So middle phalanx, okay? Is it okay to tap on the clavicle? Yes, it is fine. Tapping means with a single finger, middle finger, without keeping your other. You can keep your other finger as well, but classical textbooks describe just percussing, but it's a bit painful sometimes. Make sure you cut your nails properly, otherwise the patient will scream. And that's that. Right. Any other questions before we end? There's a small little thing now that we need to do. But any questions about the examination technique in particular? Okay. So I think that's fine then. Okay. Now we put all this together. So this doesn't take a lot of time. This is a revision now. Now, when you are faced with diagnosing a respiratory problem, okay, we look at it in a very simplistic manner. How do you put all of this together? Okay, how do you put all of this together? When you are doing the respiratory system examination, if you find that your findings are bilateral, this indicates a more diffuse pathology. Findings are bilateral. Like in abnormalities, bilateral findings. So if it's bilateral, it indicates a diffuse lung pathology. And this could be like cyanosis lung. There are only two possibilities. Similarly, in the respiratory system examination, if your findings are bilateral, there are only three possibilities that it could be: COPD, interstitial lung disease, and bronchiectasis. Now I'm going to tell you the key features in establishing the diagnosis between these three. In COPD, you can diagnose it from sight. It is a spot diagnosis. So say you have bilateral findings and you're dealing with either COPD, interstitial lung disease, or bronchiectasis. COPD is generally a spot diagnosis because the patient is dystic and usually doing that. A tripod position. So using the upper limbs to move the chest wall. Yeah, reversing the origin and insertion of the musculature. And also the shape of their chest is barrel shaped. So dystic at rest, tripod position, barrel shaped chest, very suggestive of COPD. Percussion, you will find hyperresonance because it's only air. Okay. And so hyperresonance, loss of liver dullness, all of these features. Auscultation, sometimes the breath sounds are diminished bilaterally, but you might hear a few rhonchi and crackles. So write that down then. COPD, how you diagnose it is, on inspection, the patient will be breathless using accessory muscles of respiration, maybe positioned in the tripod position, right? Patient will have a barrel-shaped chest because of hyperinflation, and you see all the signs of hyperinflation, okay? Resonant percussion, push down or impaired liver dullness, all of that you see very clearly. Auscultation, breath sounds can be diminished, and you might hear a few rhonchi and crepitations. Okay. Interstitial lung disease, the key feature is clubbing. And if you remember your modules, you will remember that interstitial lung disease is especially seen in people with connective tissue diseases. And you recently had your module exam, right? And in that you might remember patients with rheumatoid arthritis, patients with systemic sclerosis, patients with SLE have interstitial lung disease. So this patient will have features of these diseases when you examine them. So in ILD, clubbing and also a sign or stigmata of connective tissue disease like systemic sclerosis, like SLE, rheumatoid hands, then you are quite damn well sure that this could be interstitial lung disease. The third and only other important finding that you will see is the basal fine crackles, end inspiratory. Remember, when we were talking about crackles, we talked about fine basal end inspiratory crackles. So that's for ILD. Diffuse pathology number 3, bronchiectasis. Bronchiectasis is basically, clubbing again is a feature of bronchiectasis. And the other key feature is when you auscultate them, so the most important feature of bronchiectasis is very coarse, inspiratory, expiratory, coarse crackles, usually at the bases predominantly, but can extend everywhere. That based on how much disease extent the patient has. So diffuse lung pathology ඔය තුන තමයි අපිට එන්නේ. So findings are bilateral. COPD easily diagnosed on inspection, barrel-shaped chest, features of hyperinflation of the chest. ILD, looking for clubbing, peripherals, features or stigmata of connective tissue disorders, very important. And when you ask them to breathe, the inspiratory crackles in the bases are a key feature of interstitial lung disease. Bronchiectasis, clubbing is a feature again, and also the crackles are very, very coarse and harsh and loud. And they are heard inspiration, expiration. Right. Then you can also have, you can look at this picture again. So we talked about the diffuse lung pathology. So write all these down about each disease. These are the key features to diagnose each of these 3 diseases. Now see, when you're doing the examination, it's a localized problem. Okay? In one area only. Then you're dealing now with a localized lung problem. Localized lung problem. And this could be any one of this. Effusion, consolidation, fibrosis, cavity, collapse, mass, and pneumothorax. Right. Okay, could be any one of these 1, 2, 3, 4, 5, 6, 7 things. Hari, then we need to do this now. Okay. And before we move on to this, ask one question Purna has asked. Can you palpate the trachea in the supine position? That's okay, but not preferred. You can do it. But try to get the patient 45 degrees. Usually exam make 45 degrees then patient. Now I want you to fill this up. Ari, fill this table up. And then I will go through this one by one with you again in about 2 to 3 minutes. Okay. Ari. So now what we are trying to do is we are trying to, this is very difficult to do like this online, but let me see. So write down all the features of effusion, consolidation, fibrosis, cavity collapse, mass, and pneumothorax. General examination, what are the findings? Trachea, where is the trachea? What do you find on inspection? What do you find on palpation? And then percussion and auscultation. And we will revise all of the things that we have just discussed now. Hi. Puro balan. So fill it with me. I don't know what the hell you buggers are doing. So without wasting time, we will do this together then. Effusion, is there anything in the general examination? Usually no. Okay, usually nothing specific. Neither. General exam again, nothing specific for effusion. What will happen to the trachea in an effusion? If it's a massive effusion, the trachea will be pushed. Remember, if it's a massive effusion, pushed to the opposite side. In a massive effusion. Okay, massive. Abay, be mindful of the fact, and this is one of the very famous questions. I can still remember myself as a medical student going for the final exam and getting the most dreaded examiner that you can imagine. That not chutta Venus, but those days the dreaded examiner was Professor Sham Fernando. And basically, if you got him, you have a very high likelihood of failing the exam. And basically, in my group on my day, 10 denek gaya Sham sir langata, 8 denek fail. Okay, so that obviously is rather surprising. And those days it was multiple cases by the same person, so I got him for CVS and RS, I think. And one of the famous questions he asked, I got a massive effusion, very easy bloody case, respiratory system, kahapu gamam badu thiyena. And he asked me, right, but the trachea was unusually not displaced. Now, if it's a massive effusion, the trachea should be pushed to the opposite side. So why is it not? The reason for that is, in a very massive effusion, something else can happen. The underlying lung can collapse in some cases. Okay, underlying lung can collapse. So then, now what will happen? The massive pleural effusion is pushing the trachea. The underlying lung has now collapsed, which is now pulling the trachea. So the net effect could be in the midline. Now the net effect is in the midline. So effusion, trachea is, if it's a massive effusion, it's pushed to the opposite side. But remember, it can still be in the midline because in a massive effusion, the underlying lung can collapse. And the net effect of pushing and pulling because of the collapse is in the midline. Inspection, monavada venne? Inspection, obviously you will see movements reduce. So reduced movements in that area. Alright. Then what happens to vocal fremitus? Vocal fremitus is reduced. Why? Because vocal fremitus is reduced. Because now remember what we are checking vocal fremitus. I taught you that we are checking the vibration going down through the bronchial tree across the chest wall onto your hand. In a pleural effusion, there is fluid in the pleural space which is stripping the pleurae apart, and that causes reduction in vocal fremitus. I'm sorry, I'm talking about palpation. I'm sorry. So inspection is just reduced movements. Palpation, reduced vocal fremitus. Okay, reduced vocal fremitus and also reduced movements. All right. Okay. Right. I hope that's fine. Percussion, we know that over effusion you get a stony dull percussion. Revise, remember, stony dull percussion kiyanne you're getting a very stony sensation to your palpating finger, the finger on the chest wall. That is what stony dull means. Dull just means it's still springy. The feeling is still springy, but the tone is reduced. The note is dampened. So it is stony dull percussion. Stony dull. Auscultation. Auscultation is basically breath sounds absent on that side or significantly reduced on that side. Okay, breath sounds absent or significantly reduced. This is partly because the lung is also collapsing with the effusion. And as I told you, you might hear bronchial breathing on the upper border of the effusion. Find out why that is. But the breath sounds are reduced. That's about effusion. So effusion, nothing special in the general examination. Trachea is pushed to the opposite side. Reduced movements on inspection. The vocal fremitus is reduced. Movements are reduced when you check the chest wall movements. Stony dull percussion and breath sounds reduced with a bronchial breathing above the effusion. Trachea is important. Remember, trachea can be in the midline as an exception if there is a significant collapse of the underlying lung. Consolidation. Now, consolidation, remember, is what you get in lobar pneumonia, where there is fluid in the alveolar space. Trachea ekata monawath veida? No. So trachea is in the midline. Remember, trachea is not central. Trachea is never central. It is anterior. So use the word midline. Okay, so trachea is in the midline. Don't use the word central. That's the wrong word. So trachea is in the midline of consolidation. inspection, you might see reduced movements, right, in that area. So if it's a large lobe involved and the alveoli are full of fluid, you might see reduced movement in that area. Harida? What happens to the vocal fremitus? Okay. Vocal fremitus, basically what happens, now the lung, remember, is more solid. Pathology, you might remember, if you remember your pathology and in your respiratory module, they talked about the pathology of lobar pathology of lobar consolidation. Probably me that taught you buggers also. So pathology of lobar consolidation, you're getting something called hepatization, where the lung tissue is more solidified. It's like the liver. So remember, vocal fremitus, if it's a solid, it transmits, vibrates better. So therefore, vocal fremitus is increased. And obviously, movements are reduced. So reduced movements. Percussion is dull. It's not stony dull. It is dull because there's water in percuss karnakota dullness එකක්. Okay. Auscultation, bronchial breathing is a characteristic feature. Bronchial breathing, and the breath sounds will be reduced in intensity, but basically it's bronchial breathing. Because why is it? Because you get bronchial breathing, the alveoli are filled of fluid. So this alveolar filter that usually filters off the harsh, high-pitched sounds that you get from your trachea and proximal airways are no longer filtered off. So therefore you hear this very harsh sound, inspirating, expirating, gap between the two, and a long expiratory phase. Harida? So that is what you get in con. And you can also check for whispering pectrilaki, which is a feature of in that area. Right? Rahasing ekai dekai tunai hatarai kiyanukota eka saddeta ahen. Hondata clearly ahen. Fibrosis. So again, consolidation, trachea is in the midline, reduced movements in the affected area, vocal fremitus increase because the lung is more like the liver, it is solidified, hepatization, and then you get increased vocal fremitus, and then also you get dull percussion and a bronchial breathing patch because the alveolar filter is not working, it is blocked with fluid, and then you hear the high-pitched, harsh sounds. Right. Moving on to fibrosis. Fibrosis, what will happen? Trachea, when there is fibro, here we are talking, remember, about apical fibrosis. So write that down, apical, specifically that's the only common case of fibrosis you will get. Apical fibrosis, lung shrinks and therefore trachea is same side, pulled to the same side, deviated to the same side. Inspection, very clear, this lung is destroyed, it is just fibrous tissue, so reduced movements in that area. And also I have to tell you that a key feature of apical fibrosis is apical flattening. I showed you a picture of that. Apical flattening is the key feature, because it's shrinking of the lung tissue in that area. Palpation, you will see the reduced movements with your hands as well, you will observe that. And what will happen to the vocal fremitus? Again, like in consolidation, now it's further solid. It's collagen, it's really solid. So it transmits very well. And then the vocal fremitus therefore is increased. Okay? Because it very well, hondata transmit, hondata vibrate, so you get increase. Percussion, it's a solid, so dull, but not stony dull. And again, bronchial breathing. Because again, this alveolar filter is destroyed, the alveoli are destroyed in a fibrosis area, so therefore you get bronchial breathing. Right. So fibrosis, trachea is deviated to the same side, reduced movements, apical fibrosis on inspection, apical flattening on inspection, increased vocal fremitus, dull percussion, bronchial breathing. Okay. Cavity, the only thing that you get is lung එක හිලක් තියෙනකොට bronchial breathing. And that bronchial breathing is called cavernous bronchial breathing. Listen to, there are many tapes of this on YouTube, I think, and there are some websites that give you these lung sounds. Listen to that specifically. And you also get another feature which I need you to find out for homework. what is the other feature you get in a cavity? I will tell you the name, otherwise you will go all over finding for it. It is called post-tussive suction. Post-tussive suction. And also find out what the crackpot sign is. Cracked pot sign. Okay. Homework එකට ඔය දෙක මොකක්ද කියලා හොයාගන්න පුළුවන් නම් හොඳයි. Okay. Cracked pot sign and post-tussive suction. What do you mean by post-tussive suction? Post-tussive suction. Those are all physical signs associated with the cavity. Find out what they are. හරි ළමයි. Exam එකේ ඔයගොල්ලන්ට දෙන cases ටික ඔය ටික තමයි. Effusion, consolidation, fibrosis, cavity. And also the other ones that we described. COPD, ILD, bronchitis. And these are exam එකට විතරක් නෙවෙයි. Commonly what you see in clinical practice are also these pathologies. Right. Now we'll spend the next 5 or so minutes on the other 3 things. In a lung collapse, what will happen? This is a total lung collapse, remember. What is the surgical equivalent of a total lung collapse? A pneumonectomy. Pneumonectomy. Trachea, obviously if your lung collapses, same side. Movements will be reduced. And you will not hear any breath sounds. No breath sounds. No breath sounds. Dull percussion. Okay. Reduced movements. Vocal fremitus is absent. Because there is no air entering the lung. Lung එකක් නෑ දැන්. Imagine like a pneumonectomy. Lung එක අයින් කරා වගේ. So no vocal fremitus or reduced vocal fremitus. There's no vocal fremitus. That's a better way of expressing that. No vocal fremitus. Now this is a pneumonectomy. So then I'm going to give you the next homework. අනේ ළමයි මේ homework එක කරන්න දැන් බැරි නම් appointment එකට යන්න කලින් හරි. So what is the first homework? Find out what the post-tussive suction means and also find out what you mean by a cracked pot sign. Okay, these are features of cavities. I have shown you the physical signs of a full lung collapse, or easier to think of it as a pneumonectomy. The pneumonectomy lung එකම අයින් කරා වගේ. Now I need you to work out for homework what happens if a single lobe collapses or a segment of the lung collapses. So this is called a lobar or segmental collapse. Lobar or segmental collapse. Find out what the physical signs of that are. Okay, what the physical signs of that are. And I think it will be useful if both of this homework before tomorrow somebody put it on your WhatsApp group. නැත්නම් උඹලා හැමෝම මේ කීරත් කරන්නේ නැහැ නේ අරුතර එකෙක් හොයාගත්ත එකක්වත් කියවලා එකෙන් යම්කිසි දෙයක් ඉගෙන ගන්න. So somebody, if you can find out these 3 things. So number 1, what happens, what does a post-tussive suction mean? What does the cracked pot sign mean? And what do you get if you have a lobar or segmental collapse? What are the physical signs of a lobar or segmental collapse? That is like a lobectomy. Lobectomy. කෑල්ලයි අයින් කරන්නේ. Now I have given you the physical signs of a total lung collapse. So that is your second homework. Lung mass. As I told you right at the start, a lung mass is best diagnosed on the general examination. මොනවද තියෙන්නේ? Horner syndrome, pressure effects, Horner syndrome, SVC obstruction, lymph nodes. Okay, these sort of things you will find. And clubbing. So if we කරුමෙටවත් ඔයගොල්ලන්ට lung mass එකක් cancer එකක් දුන්නොත් exam එකට, it is best diagnosed not from the respiratory examination. It is best diagnosed from the general examination, looking for Horner syndrome, SVC obstruction, lymph nodes, clubbing වගේ දේවල්. And what can happen is a mass can do several things. Okay, it can just act as a space occupying lesion in the lung, or it can cause a consolidation of the lung. So for example, if it occurs in a bronchus, it might cause consolidation, or it might cause a collapse of a lung. In its physical signs are variable. It might even cause a pleural effusion. So remember that a lung mass can present with collapse, can present like a consolidation, can present with effusion, or can present purely as a solid space occupying mass. Okay, space occupying mass which actually pushes, if it's a space occupying lesion, it pushes the trachea away. Okay, but it can present like anything, so it's very, very difficult to diagnose, and it is best diagnosed from the general examination. Last but not least, pneumothorax. Remember, you will never get a pneumothorax for your exam, but you will see this in practice, and remember that you need to know how to diagnose this. Okay, so trachea shifted to the opposite side. Okay, shifted to the opposite side because of the gas pushing the mediastinum. Inspection, obviously, reduced movement. The lung is collapsing. When you see a pneumothorax, the lung is collapsing. So no vocal fremitus. It's like a collapse. The no vocal fremitus. Mukut nahe. Lung ekak nahe. It's all collapse. And reduced movements. Percussion is where you make the diagnosis of a pneumothorax, and that is resonant. 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 Hyper resonant is other word. And breath sounds are absent. Breath sounds are absent. Because why? The lung is collapsed. Okay. Haridhar? So, pneumothorax, trachea to the opposite side, reduced movements, no vocal fremitus, resonant percussion, and no breath sounds. Mass, go by general exam because it can present in any way. It can present with effusion, it can present like a consolidation, it can present like a space occupying lesion, it can present like a collapse. If there is a tumor in the large bronchus, it can present as a collapse. Okay, so it can present anyway, but most important thing, it causes all these nice findings on general examination where you establish the diagnosis through that. Hi. So just to quickly summarize what we've done, we have discussed that interpretation of physical signs in the respiratory system. If your findings are diffuse, you have three options: COPD, ILD, or bronchiectasis. The findings are bilateral. COPD, you get features of hyperinflation, respiratory distress. ILD, clubbing, features of connective tissue disorders, and fine end inspiratory crackles. Okay. Bronchiectasis, clubbing, and also coarse, harsh, very loud sounding catacrackles. If it's a unilateral problem where findings are only on one side, it could be an effusion, it could be a consolidation, it could be fibrosis, it could be a cavity. Those four things are the most common things you encounter in clinical practice and the most common things that you get for the exam, therefore. But exams, you can get these rare, wonderful things. Collapse because the patient is very dyspneic because of the collapse. Mass, yes, you can get a mass because a mass can cause features of a fusion, can cause features of a consolidation, for example. Okay, but in the mass, the most important thing is you get general examination signs like Horner's syndrome if it's in the apex, SVC obstruction, lymph nodes, and club. Pneumothorax very rarely seen in the exam, but important in clinical practice for you to learn how to diagnose it. Trachea pushed to the opposite side, reduced movements, and absent vocal fremitus and breath sounds. Okay, that's what you get in each of these conditions. So for homework, remember post-tussive suction, you need to know what that is. Cracked pot sign, what that means, and also find out what happens if you have a segmental or lobar collapse. That is only part of the lung is collapsing, not the whole lung. Okay, so that's it then for today. We have discussed interpretation of physical signs and examination technique of the respiratory system. So further questions, please ask. Wait again. Okay. Fine. So Sanjay asks, if chest movements are driven by muscles, diaphragm, intercostal, how does it reduce movements by pathology? Right. So that's actually a very interesting question. So it's, yes, it is the muscles that drive it, but it is also the filling of air into the lung that drives it. Even though the muscles are normal, if there is no no air entering the lung, the pressure differences are, if as you know, it is all this negative pressure build up that drives the breathing movements. So if there is no lung tissue for air to come in, there is no generation of this negative pressure for the lung, for the movement to occur. Okay, that's why. Okay. Any other questions about the physical science? So make sure you do the homework, and also make sure that you do yesterday's homework on the cardiovascular system. Right. So it is a bit challenging to do this online. I usually do this with a patient and with a lot of other material, but I've tried my best to try to do this at least to about 70% or 80% what I usually do. It's very difficult to do it online, this sort of clinical class, but let's hope that you get something out of this. Purna, yes, do you need to palpate the cardiac apex? Not essential, Purna. Not essential. No. Okay. Doesn't give a much doesn't give much additional benefit. Hari? Okay. Sarangani, is that okay?
Yes, sir, it's okay.
Right. So I will post this on the classroom thingy.
Okay.
And tomorrow same time, okay?
Yes, sir. Okay, that's fine.
Yeah. So tomorrow we will do the abdomen, and then obviously it's a weekend, and on Monday, Tuesday we will do the nervous system, cranial nerves on the first day, and then limbs on the second day.
Right.
Okay. If you have any questions, please post them on the WhatsApp group. And it would be good if somebody can post the homework answers on the WhatsApp group also. Okay. Yesterday's questions. Sarangani, do you have the new updated short case, long case books? Mange, do you have those? The new ones?
I don't think it's the new ones.
Still have the older Paranamang medical student Kalya.
I think so, sir.
Right. So I will send you the new ones. It's okay. Not for circulation freely. I know these photocopy shop people earn a lot of money by printing out these books, and they're probably earn millions by now. But it's only for use of your batch. Huh? So it's the new version is only with you, and I've given the 2003 people, sorry, 2013 people as well. So I'll give it to you just for your batch, for internal circulation only. Yeah. Mama classroom එකේ දාන්නම් කො එතකොට එතනින් ගන්න පුළුවන්. I'll post soft copies in the classroom. Then it's only for you guys. Right?
Thank you.
Okay. Right. Okay. See you tomorrow then.